room, and we will put all of the participants on mute. Great, I think we'll get started. Good morning from Nairobi. My name is Jessica Gorham, and I am the Regional Emergency GBV Advisor, working on behalf of the GBV AoR in East and Southern Africa. And I am joined today by my colleagues, Leah Ashley, who is the Riga based in Asia Pacific. She will be co-facilitating today's webinar with myself. And we are getting support from Alexina Russeri, who is the Riga in the MENA region, and then also from Pam Godoy, who is also part of the Asia Pacific team. They will be monitoring the chat today. So please, if you have any questions, please do write them in the chat. Similar to our previous webinars, they will be very good about making sure that your questions are noted. We will only be addressing questions at the end of the webinar to ensure that all of our speakers are able to present. And then based on time, we will cull and go through the questions to make sure that we have a broad range for all of our speakers. We will have all of our participants on mute. So it's very helpful if you could, again, write your questions in the chat. And then also, as in the past, the recordings of these webinars and all other resources that we reference during the webinar can be found on our website. And that's gbvaor.net. Next slide. We are nearing the end of our series, so we will continue. Next week is the last of our series for the webinar, and then we will go to a monthly format, but we'll be sure to apprise you of how that is going to unfold. I'm really happy that today we have some really great presenters who will be showcasing their work in different countries. Our first speaker will be Julian Lusenge, who is the head of a local organization in the DRC, Women's Solidarity for Peace and Integral Development, and also the Congolese Fund for Women in the Democratic Republic of Congo. She will talk about some of the ways they have adapted their programming for COVID-19. Next, we will have Gloria Chakia from South Sudan. She is a GBV program manager for HealthLink South Sudan. She will also talk about, within her context, how they have adapted their programming for community level. And then finally, we'll have Noha Yeha, who is from the Yemen Women's Union and then also GBV subcluster co-coordinator for Yemen. Next, we will look at considerations for the GBV subcluster and GBV coordinators. We will have the GBV subcluster coordinator from Yemen, Hala Al-Akel. And then, of course, we'll have resources and then our question and answer session. So I know we were a little bit late getting started today because of some technical issues. So let's start with our first speaker. Julien, if you can unmute yourself and we'll get started. Welcome, Julien.
Okay.
Julien?
Thank you.
Great, we can hear you well.
Can I open the camera or I can just speak on audio? Yes?
I think without camera might be better, just speak for the connection.
Can I open the camera or not? No?
No camera, just because of the connection might be a little bit difficult.
Yes. Okay.
But thank you.
Okay. Good morning, everyone. Good morning, everyone. I will just introduce the Sophie Padi work and the FFC. Since 20 years now, Sofepadi offers holistic support to survivors in Bunia and Beni. Now we had also opened an office in Kinshasa 5 years ago. We have a one-stop center in Bunia, and we hope that this year we will open a medical center in Beni and Kinshasa, thanks to EU. Sofepadi organized also peace dialogue in different villages. At 2007, we create FFC, Congolese Women's Fund, because we believe on collective efforts of women. FFC is a feminist fund and a bridge between donors and women's group. We give technical support and financial support and build women's movement in DRC. How we adapt our strategy to continue to promote women's rights in DRC. The adaptation is a key word to respond to new challenges for women and girls in the context of COVID-19. In Ituri, some visit and supervision for Sofepadi's staff suspended but kept mobile clinic with limited number of patients. We care in the community psychosocial assistance by women's leaders and by ourselves, by phone. Information to community is done by women leaders and some survivor, previously trained. We increased also in radio and online message. We protection material at our services provision point Karibuni wa Mama. It's a Sofepadi hospital in Bunia, our one-stop center. New item is equipment we give to FFC staff. It's not FFC, that's because this is a Kabila platform political, but we call Congolese Women Fund is FFC. Evaluation of new needs and adaptation of advocacy. Next slide. Yeah, we do also assessment to know what is the need in the village. We ask people by phone, or we have these leaders, women in the village, who send us the message to know the needs of the women in the village. Next slide, please. Okay. What is the innovation we done? Work on intimate partner violence, IPV. We do monitoring and reported cases, prevention message on IPV, communication campaign, broadcasted in community, based and local radio in local languages, online and national TV in 4 DRC official languages, plus French. Engagement of the special counselor to head of state on VAU. And we do our advocacy also to parliamentarians and Minister of Gender, Family and Child for law reform to integrate IPV as new infraction in the penal code to review the existing law against sexual violence. To the international organization and the bilateral donors to support national and local organizations, providing flexible funding and support for emergency response, as well as development assistance. Next, please. Next slide. Okay. We are also a member of some consortium, Solidarity in Kinshasa, to give support directly of some women who are in need, and we send message online to give message to how people can protect themselves in the community, or how they can help. Next slide. Next, please. Okay, what is our perspectives? To strengthen women leadership and to ensure that the needs of women and girls are integrated in humanitarian planning for the response to COVID-19. We give emergency grants to 20 women groups in Kinshasa, Goma, Bukavu, Oicha, Beni. Financial support to the National Association of Psychologists in Kinshasa to provide psychosocial support to people affected with COVID-19 and their family. Organization of a network of women to share monthly reports on women and girls during COVID-19 time. Use of WhatsApp to create a large platform, equipment, and Android phone to women group in need. Organization of online training in French and Swahili for correct use of social media and Skype and Zoom, so they can be able to participate on a webinar in the world. That is our perspective.
Thank you, Julian. I think there's so many interesting tidbits from your presentation that we could really learn from. First, I was happy to see that everyone you mentioned were either community-based organizations or women-led organizations that are being empowered in a way to lead this response. And I think one of the last points you made about organizing online training about how to even use social media, Skype, and Zoom so that they can be active participants. I think that's a really great takeaway. And then also how you're really relying on those people, those community members you have trained in previous programming to be the frontline service providers of messaging in the COVID-19 response. So thank you very much for your presentation. And I think we'll see if we have questions at the end. And then now we're going to go to Gloria, who is the GBV Program Manager for HealthLink South Sudan. And she'll talk a little bit about how they have adapted their programming due to the COVID-19 pandemic. Gloria?
Thank you.
Great, we can hear you well, Gloria. Thank you.
Welcome. Yeah, HealthLink South Sudan is a national organization that has been working with women and girls under the GBV response and prevention programming for over 5 years. And we have been having static programming both under emergency and under emergency funds and multi-year funding from our different donors like DFID, UNFPA, South Sudan Humanitarian Fund, among others, but with always support from the GBV subcluster South Sudan. On 23rd of March, the government of South Sudan banned all inbound and outbound flights and mass gathering in an attempt to prevent the spread of COVID-19. And also interstate flights have been restricted on the essential flights, which carry on cargos with life-saving supplies. And then civil servants and government workers only work for half day. And all this is being to ensure that there is an attempt to to prevent the spread of COVID-19 in the country. As well, during the first quarter of the year when the GBV AoR data analysis was conducted, HealthLink is one of the data gathering organizations for information management system for the country. It has been realized that intimate partner violence cases have been so high in the last month. During our analysis, we tried to relate this to the lockdown issues, because if the comparison to the previous quarters and the previous months, it has not been the case. Therefore, more of our focus has also now gone into providing counseling related to IPE, intimate partner violence, which has been associated with the lockdown and the economic crisis issues in the country. Next slide. Yeah, our case management model somehow has changed a bit, because we look at case management as a life-saving service to survivors of GBV, which if we do not really support on time, we will actually be creating more impact alongside the impact of COVID-19, which was already there, which is already actually happening in the country. So previously, we have our case management centers established at the women and girls friendly spaces, where often all the case workers, because we have more than 3 to 4 case workers stationed in each case management space at the women and girls friendly spaces. So there was very minimal space, and most time the space has been crowded. So not to completely suspend services for survivors, as I had mentioned that case management service is a life-saving service, we have moved the case management to our office spaces. This is just to ensure that there's social distancing, and then there's also personal protection, both for the case workers, and then as well for the survivors who come accessing this. And then where we have moved it to, at least we are able to create a 1 meter kind of distance between the case worker and then the survivor. And then as well, we have also stationed the hand washing stands right at the entrance of the gate as well. Also, we have the hand sanitizers in the case management rooms that we have established as emergency support for during the COVID-19 crisis. And then also another modality that we have changed is like we have shifted the turn up of case workers to support the services into numbers, like instead of them coming all like how they used to come on daily basis, this time around we have shifted like only 1 case worker comes in a day to support case management services in case survivors show up for cases at the changed case management spaces in the office space. And all this we're just doing it to create and maintain the social distancing standards that have been put forth by WHO. And then another thing that we have also changed a bit about our case management service provision is our intake form. Our intake forms. We have been doing face-to-face intake forms for all cases, but we realized that we might not be able to have this when the turnover is very high during the COVID-19 crisis. So we now do on-call casework facilitations. We have phones that we have now stationed in all our case management points that we have relocated to our office space. And these numbers have already been given out because we have an existing referral pathway. And HealthLink also is one of the lead partners for the state GBV subcluster coordination meetings. So the survivors are able to call these numbers, to reach out on these numbers, and the caseworkers are able to assess their immediate need of response. Is it a health service response? Does it need a psychosocial support service response? So this also helps in reducing the survivor moving multiple times to the office space where we have created for case management service, which also helps to minimize the distancing, to minimize them moving more than 5 times or in order for that particular service, because we still work with the existing referral pathway. We have the contacts of where they can be referred to. So this is another approach that we have now brought in during the COVID-19 crisis. Next slide. Lastly, we still, to South Sudan context, we still realize that the psychosocial support service provision during the COVID-19 crisis is very crucial. And to our context, we look at it as still a life-saving service. We have been running activities in women and girls friendly space whole day long, from morning up to from 8:30 up to 5. And we have never limited the number of people who come and participate in these activities. But from the government banning of gathering, as Lorena says, South Sudan context is a bit quite different from the other contexts. We still have the opportunity where we can still do our activities now in shifts. We have limited the number of people maximally up to 15. This 15 number, we are able to maintain the social distancing in it, because we have mats, we have chairs where at the women and girls friendly spaces where they are able to sit and practice social distancing, but at least some activities move on. Because some of these psychosocial support activities are what keeps the women and girls' daily life moving. So that is how we have changed a bit with our psychosocial support activities participation. And then also we've gone further, like installing hand washing facilities with soap right at the gate of the women and girls friendly space. We have the opportunity that our women and girls friendly space are being fenced. So we are able to control the number of people that we really need in a day in order to move on with activities. So at least there's hygiene maintenance standards throughout the sessions. And then also we have placed like the IEC materials about COVID-19 prevention messages, science developed. These materials are being standardized by WHO and then Ministry of Health, South Sudan, which most partners are using, passing messages to the community about it. So this is the same thing that we are also using to women and girls who come to our at the friendly space, because this is where they always get messages from. So we felt like this is also part of life-saving messages to them, that about the preventive measures, about the signs that, and we also let them know in case of the signs, where do they need to report to and all that. And this is always simplified in the local language such that they are able to understand it very clearly. So apparently that is how we have zeroed down our life-saving activities for women and girls in our programming. Thank you.
Thank you, Gloria. That was a really good, concise way to let us know how you've been adapting your services. And I think this one is especially relevant as well, because many of our members have asked about women and girl-friendly spaces and how we can adapt those services. And so some of the things I've heard from you is, and maybe others also might want to take note, is that you've changed the location of your counseling sessions. You've reduced those sessions. And then you've also taken on the remote intake, so to reduce the amount of time that people need to congregate together, and then to also account for the increase in reporting, and so that people can then go, you can determine quite quickly if it's a life-saving referral to health and other facilities. And I liked how you kept stressing throughout your presentation that these are essential life-saving activities to make sure that women and girls are protected in South Sudan. So thank you very much, Gloria. And now I'm going to turn it over to my colleague, Leah Ashley, who will guide us through the rest of the webinar. Leah Ashley?
Thank you so much, Jessica, and to Julian and Gloria. I really appreciate those practical examples that you shared, and I find your leadership for women-led organizations and local organizations really inspiring. So I think that's the perfect entree to move on to our next course. And I'd like to introduce everyone to our speakers and who will be providing insights from local organizations in the Middle East and North Africa region today. First, Ms. Noha Yeha will explain to us how Yemen Women's Union is continuing to provide frontline services in the COVID context, overlaid on the humanitarian response to conflict affected areas, as well as other public health issues. Noha is also the co-coordinator of the GBV subcluster in Yemen, and Yemen Women's Union is a leader as one of the first local women's organizations to become a national level coordination co-chair. So Noha will be able to answer your questions today related to that. And finally, our GBV subcluster coordinator from Yemen, Dr. Halwa, will share with us some of her practical tips. Again, Yemen's subcluster has been a leader in contextualizing and disseminating training and skills on GBV coordination to local organizations. So we're very excited to have you both with us, and over to you, Noha.
Thank you, Leah Ashley. Hi, everyone. I'm so happy to be with you today and to share the experience of the Yemen Women Union. In the beginning, I will give you a brief about Yemen Women Union. It's one of the oldest organizations, women-led organization in Yemen. It was established in 1963. Yemen Women Union has more than 1,400,000 members of women, and it has 23 branches all over Yemen, and more than 165 women centers at the district level. As a women-led organizations, we are prepared, and we have our preparedness plan to respond to the COVID-19 in case it outbreak in Yemen. For the time being, only one case was confirmed in Hadramaut and in the South Yemen, but now he was recovered, and no cases reported. However, we're still working on our preparedness plans. For GBV programs, we are operating 19 safe spaces in 14 governorates, and we have 8 safe shelters at in several governorates. We are working on preventing child marriages and other life-saving projects. Our main focus is on women and girls. Of course, we have we adapted so many activities and services to COVID-19. Our main focus is the survivors. So we worked on enabling the survivors themselves to be active in the preparedness and prevention of COVID-19. The safe spaces before the COVID, we used to provide them with the trainings like handicraft, incense, and first aid, etc. But to enable them to be active members in responding to COVID, the trainings shifted to be for these survivors to be on making face masks, sanitizers, and help them to distribute them and sell them in the community. There's a shortage in Yemen for face masks and sanitizers, so we used this opportunity and provided training for these women. Of course, there is specific measures that we use, safety measures that we used for these women. The number of the participants in each training do not exceed 15 participants, and we ensure the distancing and all other safety procedures during these trainings. And also we used we also trained them. It's like providing awareness raising on the preventive measures of to COVID, and we introduce them on their role in awareness raising and how to their impact on empowering the community. Also, as one of the oldest organization and have that's working nationwide, we have our hotline, which is well informed by the communities. We started to use the community networks, and the women networks, men-to-men networks, to inform the community that this hotline will be used as well for case management, for referral, and for providing psychological support in case they cannot reach to these to the safe spaces, or to the case managers, or to the centers of the Yemen Women Union. For the communication with the local communities, as we have been working in the communities for years, we are well known, and we have our very well trained community members who is supporting the Yemen Women Union initiatives and activities of awareness raising, and facilitate the communication with the community. Um, we integrate communities at micro level through various approaches, such as we have a men-to-men network, community networks, women awareness raising committees, and also this committee actually is consist of teachers, community leaders, religious men, influential people in the community, and these people are used to do the communication with the community. For example, now they are doing like one-to-one awareness raising about COVID-19 and the protection measures that the household should take. They start to introduce the community on how to get the GBV services in case COVID outbreak in Yemen and there was no safe spaces open, etc., etc. So they start to introduce them how to use the hotline and how to get the services. The hotline services is a bit challenging in some districts because there is no networks, or in some places women cannot have a mobile. So the alternative is that this community members is well trusted, and the community, the survivors usually approach them to learn about the services. So one of the things that they can use their mobiles, or this community network can facilitate having a place where these survivors can have a calls in case they don't have a network for a mobile, so they can use landline from one of the places with this community networks. Also, for a practical measures that we used for taking care of the staff, as a preparedness plan by the government, there was a downsizing for the staff. There was, instruction to downsize the staff of safe spaces, of all, actually of all offices or organization. They have to downsize their staff. So what we did is that we downsized the staff of the safe spaces to 20%. We kept the management of the safe spaces, the psychological support, and the case manager in many places. We kept the safe spaces opened, and we reduced the number of the training, as I mentioned earlier, the trainees who came and the visitors who came to the safe spaces. We still do, for the psychological support, we are doing individual instead of group support. We now start receiving individual, providing also, focusing on providing individual psychological support for the survivors. Sanitizers, sanitary gloves, face masks distributed, and that the staff was trained on how to use them and the importance of using them. We have anyone enter to the safe spaces, they have to be sprayed with ethanol for the safety of everyone. And for when it's possible and there's no pressure in work, the staff is working from home. So to follow the to ensure their safety. Thank you.
Thank you very, very much, Noha. I learned a lot from your presentation. One thing that I think is really important that you highlighted is, you know, the role of women as frontline humanitarians, but not just women, but survivors as frontline humanitarian providers. So getting away from the narrative of passive recipients, but that survivors are active participants in the humanitarian response. I really appreciate that point. And also you highlighted the way that you're engaging men and boys, religious leaders, teachers, community members in disseminating information on the referral pathways since they've been revised for the COVID response. And then I also really appreciate how you've adapted your psychosocial support to individual service provision as opposed to the group approach. And I'm sure there'll be many lessons learned from that, and we'll be coming back to you in the coming months to see how that has gone. Thank you so much. So now I think I'll hand over to Hawa to take us to the next step to talk about practical tips for coordination.
Yeah, hi everybody, good morning from Yemen. Thank you, Noha, and I really would like to thank the Yemen Women Union because they are really strong, trusted, and respected on the ground. So actually, the subcluster is accessing a majority of Yemeni women everywhere on the Yemeni land through Women Union. So we do appreciate that. Thank you very much. Thank you, Lee Ashley and the team for giving us the chance to talk about our experience in GBV coordination in Yemen under the COVID circumstances. Actually, it is clear to everybody that GBV situation in Yemen maybe is facing more intensity of the situation as it is very intense, and we don't have access to provide services as much as we want based on some of the restrictions are based from the authorities in the country. So actually working in GBV in Yemen is already, I would like to call it fun because it is challenging. So somehow you need to trigger your creativity. So having the COVID situation, it's added a layer of the need of us to intense our creative approach in working. So basically speaking, there were steps that were done to support the partners and trying to keep things into the GBV perspective, not to have women and girls to be forgotten under the everybody is very well occupied with the current situation. So basically speaking, the subcluster issued a document that explains the GBV dynamic in Yemen under the COVID situation. So this document was a triggering point about focusing that GBV is priority. Why? Because things like domestic violence are going to increase under the lockdown. Also, as a support to our partners, we came up with guidance support about how to manage the activities or how services under the lockdown. These two documents were based at the very beginning of the crisis. We also, the subcluster joined the MHPSS COVID task force. So we were able to issue messages, and actually thanks to the AoR, they helped us a lot with this, mental health managers addressing women and girls and female health service providers. These messages, in addition to the mapping of the hotlines available already in the country, are into IEC material, and it is distributed across the country now just to keep things going. we also launched the online learning platform. And let me here just like put you into the perspective of what happened in Yemen in the first few weeks of the pandemic. Actually, what happened was we received strict information from the government to stop meetings, activities, and majority of the services. Parallel to that, we were faced by neighboring country were deporting Yemeni people and Somalian, Ethiopians, and other migrant or refugees in those countries. They were deported. Practically, they were thrown at the Yemeni borders. Also, people who were coming from KSA as were visiting Mecca, they were coming back through land, and they were put all together in, like, it was called quarantine centers. In addition to the migrant entry point between governorate, they had these quarantine centers or detention centers. Women, girls, female-headed household, men. You can imagine the mixture of people were thrown all together on those quarantine/detention centers. The numbers were growing to thousands, and actually we were not able to understand what's happening inside those centers. So we had to do the mainstreaming through service providers who had the access to those centers, like the rapid response mechanism team, the WASH, health. We trained them on observing GBV issues, and we started receiving reports from them. So we were able to understand the situation and understand how to be able to provide help. This situation is now becoming less because the government started to release Yemeni people outside of their centers, and they have the 14-day quarantines. Things are falling into place now, but quarantine centers are still there. And as protection and GBV part of it, we came up with a protocol how to manage these centers, making sure that the privacy of women and girls are respected and they are very well protected. The learning platform is still ongoing. So we are engaging service providers twice weekly on protection issues, GBV, child protection, general protection, and we even have on board non-protection partners. So this is a part of the GBV mainstreaming, like the focal point across the cluster, the GBV focal point across the cluster, who are in charge of mainstream the GBV across the cluster. This is actually a huge platform, and we are really happy to have it on board. Well, for part, actually it was like to me yesterday when I was like reading it, thinking, how am I be able to communicate with local partners, especially when there is a case when there is no internet? Because till now we are being able to implement the online meetings and have things ongoing, keep the partners engaged, but through Zoom and emails. So yesterday, actually, and with discussing with the team, coordinators in the hub, they came up with the idea to create like a network of information sharing through their partners. Maybe they can do it in person, one-on-one, one-to-one, or just like creating a document, IEC material, small meetings like in big rooms where we have like 3 or 4 or partners, and repeating that. Of course, telecommunication is always can be implemented, and we can depend on it. Yeah, it is weak sometimes in Yemen, but still available. And finally, we can still hold our meetings through Zoom link. We hope we can for that. Last idea is that we are advocating for the HCT. Every week, every meeting for the HCT, we have a presentation for the cluster with GBV component about how can they provide us with the government about the continuity of the services, and for donors to keep on providing us with funds. So this is it from coordination perspective for Yemen. Thank you very much, and thank you for giving us the chance, and I will be with you for the next 20 minutes for any questions, because I have to jump to another meeting. Thank you.
Thank you so much, Dr. Hawa. I mean, I'm taking notes furiously here. A few key points that emerged for me is you really demonstrated how many actors we need to coordinate with in order to keep women and girls a high priority in this response, both as responders and as members of the affected population who are recipients of services. So you noted the MHPSS working group, the focal points across the different sectors, the humanitarian country team, and then also the subnational coordinators and subnational coordination groups are all critical in order to have a response that's effective. So thank you for sharing that. And I also appreciate that you highlighted the specific needs of migrants and refugees, and how we need to ensure that our referral pathways and our needs analysis and assessments include them throughout the response. And no doubt we'll be coming back to you to find out more about those guidelines that you collaborated with the protection cluster on for the quarantine centers. And finally, and most importantly, I'd like to say thank you for reminding us all that our work is fun and creative. So I think we should all take that home today to remember how much fun we can have doing this work and how every challenge is an opportunity for us to be creative. So thank you so much, Halwa. I will now just close us off for the substantive portion of the webinar by sharing a few key resources. Several from the GBV AoR, as Dr. Halwa mentioned in her presentation, the AoR has created a tip sheet on how to develop key messages for communities on GBV. And also just wanted to bring us back to some of our core standards, the interagency minimum standards for GBV and emergency programming, and standard 2, 3, 5, and 15 have all been addressed in our webinar today. They're worth looking at again, as well as our handbook for coordination of GBV interventions, which discusses some of these issues around localization and GBV coordination. All of these will be available at the website of the GBV AoR listed at the bottom of the slide. And lastly, I'd like to just share a few additional resources to again highlight the work of civil society, local organizations, and women organizations. Just this week, a coalition of civil society organizations, including Women Enabled, has released a briefing note specific to addressing domestic violence under COVID. And many of the topics that we discussed today are addressed in that note, as well as it provides more practical examples from the field. And for those of you who enjoy social media and blogs, Columbia University has a blog that features the voices of African feminists mobilizing against COVID-19. And it's a fun read and very useful, powerful lessons coming from the field there on how we can all band together in this crisis. And last, I'd like to highlight that UN Women in Latin America has released some tips and guidance on how to incorporate women and gender equality in the management of the COVID-19 response. And I think we've seen today how amazing women leaders are in mobilizing communities and providing adapted responses to any kind of crisis, including COVID-19. So with that, I think we're going to move to the question and answer session. And I'm going to actually ask the first question today myself because it emerged just before this webinar and our preparation. And that is many of our local organizations that are responding in this crisis are members of federations. So for example, the IFRC, or today we have online IPPF, the International Planned Parenthood Federation. So I just wanted to take a moment, since we have them online, to ask Elizabeth from IPPF if you could tell us a little bit about how local organizations that are members of a federation have been impacted by this crisis and how that's affected the GBV services.
Sure. Hi, everyone. At IPPF, we work with member associations, also known as MAs, who provide sexual and reproductive health services, including GBV services globally, to try to understand the global impact of COVID-19. IPPF sent out an impact survey to all MAs to get a better idea of how COVID-19 is affecting SRH services globally. We received 121 responses back from the MAs across 6 regions. There were 5 key findings that were highlighted. I'm going to go over them just kind of quickly, but I'm happy to follow up with questions. The first was there was a decreased access in service delivery points. So 66% of our MAs have reported that they had to actually close their SRH service sites. This equals to around 5,633 service delivery.
Can everyone hear Elizabeth?
Did I lose you?
We lost you just for a moment, but very stark numbers of SRH program closures. Please continue.
Sorry about that. Out of 121 MAs, 88% of them unfortunately have had to scale down services. So these services include contraceptive services, GBV, and safe abortions. A third point that was highlighted was that there's now a loss of skilled workforce. Unfortunately, 12 MAs have had to terminate or suspend their staff. The fourth is that there's a commodity shortage. Many MAs reported that they are either very short on SRH commodities or they're completely out of stock. And then lastly, there's limited engagement, either in the community or with SRH service providers. 37 member associations stated that their SRH staff was actually requested to help support the COVID-19 support. So they're not able to do SRH services at all. So not great numbers, but do have MAs that are adjusting their services, and they are doing telemedicine. They are dropping off supplies and medicines at home, and they're also setting up hotline support. So like many of you on this call, we're all in this together and working on new adjustments to help support survivors of GBV. And thank you all for your support and guidance during this difficult time. Thank you.
Thank you, Elizabeth. Those are certainly sobering statistics, and I really appreciate that you shared them so we can collectively advocate for the continuation of sexual reproductive health services. That also came up in Julian's presentation about how we must continue to ensure that services to respond to sexual violence are available throughout this crisis. So thank you very much. I believe that it's time to now hand over the mic to Pamela and Alexina, who will lead us through the question and answers. Over to you, Pamela.
Thank you, Lee Ashley. This is Pamela, and thank you to our excellent resource persons. Alexina and I are monitoring closely your questions. The chat box is brimming with your queries. So we have about 7 questions for now. So let's start off. Everyone is juggling many complex and competing demands to maintain critical operations in the field. So now more than ever, organizational leadership need to ensure staff safety and well-being. In this regard, how are we implementing staff care for local organizations? That's the first question. The second one, how do we ensure the availability of personal protective equipment for local and national organizations? Third questions, how are local organizations bringing visibility to gaps in life-saving and essential services for GBV survivors? And how are we advocating for continuity of services during the COVID-19 crisis? Fourth question, how are the online caseworkers managing calls when the abusive partner might be present while the GBV survivor is making the call? Fifth question, how do we ensure GBV cases in camps or camp-like settings are properly referred to life-saving services such as health and MHPSS? Number 6, do we have a checklist to carry out a rapid assessment for capacity of women-led grassroots organizations and in terms of their capacity to adapt to the COVID-19 crisis? The 7th is many are interested to learn more about the Yemen's online learning platform. So over to you, to the resource persons.
That's a lot of questions. Maybe they need a moment to gather. Could we maybe start with maybe we start with you, Hala, with the last question on the online learning platform?
Yeah. Thank you, my dear. Thank you. Actually, the platform was established or was launched in coordination with ACAPS in Jordan. We discussed the idea with them, and they were providing the logistics support. That's from the base of logistics. From the other hand, how we started as what we felt the need of the continuous education for our partners. Actually, in Yemen, we have very successful experience done in remote coaching, done with the AoR on the coordination handbook. And we managed through this program to be able to have our GBV coordinators across the country after the workshop done in Cairo through remote coaching or online coaching. So based on this idea, we decided just to keep our partners engaged because we have really gaps in the capacity of the partners. So we launched the platform based on this idea. So we had the protection and the child protection on board actually, and they loved it. So now through ACAPS, twice a week, we have a session, we have a schedule or agenda, one month agenda, and in the same time, we distribute the topics among the 3 AoR, general protection, GBV, and child protection. Our audience started by the cluster, subcluster, and GBV focal points across the cluster partners. Then the word spread and people started to ask to join in, and we expanded the platform. Based on the topic, sometimes we have more interested people than others, but we try to create a diverse topics so we can address all people. Like for GBV, we introduced how to support survivors of gender-based violence when GBV actors is not available in your area. And that was one of the most popular sessions because this is a very pressuring issue. We introduced PFA sessions, and that was like also a very popular session. One of the other sessions we are planning to do is GBV mainstreaming under COVID, shared by ISC recently. So this is basically, this is how it's done. And we can provide more guidance on one-on-one basis if someone is interested. Thank you.
Thank you so much. For our second question regarding availability of personal protective equipment, Gloria, do you want to take this question?
Yes.
Okay, go ahead, please.
Sorry, can I come again with the question?
Yes, how do local organizations ensure the availability of personal protective equipment for its staff?
Okay, thank you. To my experience, maybe because we have been having a running fund, we were able to advocate back to our donors since some of activities were put on hold. Definitely, we realized that at the end of the funding period, this money will not get spent. So we had to advocate to them if we are able to use this fund to put in place these protective equipment such that it will allow us to move on with service provision, meaning that if we do not have this in place, then definitely providing these basic life-saving services to the beneficiary will become a challenge, which was something that they looked into, and then they were able to allow us to move on with this essential protective equipment. So to me, similarly, to partners or to local organizations that have this kind of opportunities, they should seek the same kind of way to try to advocate with the donors to see how, if some allocation or realignment can be done in order to cater for this. And then secondly, we have like also the GBV subclusters through other maybe source of emergency fundings for COVID-19. They can advocate through their clusters. They can advocate through the GBV subclusters at their various respective countries to see wherein they can come in to support with this. And then also secondly, there have been a number of emergency call of proposals for emergency support, for emergency funding to support, most especially on the issues of protective gears, because continuity of services for survivors is very crucial during this COVID-19 crisis. So to us, that was how we looked in, we tried to address it at our organizational level, and it was approved, and then we found that it is working. Thank you.
Okay. Thank you so much. That's very helpful for information of other local and national organizations. So next question is related to how do local organizations advocate for continuity of local service or essential and life-saving services for GBV survivors during the COVID-19 crisis? Because we've heard that there are gaps in services, especially relating to, let's say, health, clinical management of rape, and MHPSS. And the second question is more practical, speaking to the work of the online caseworkers. How do they manage calls when there are cases when the abusive partner might be present while the survivor is making that particular call? So over to the resource persons.
All right, thank you. This is Gloria still responding again.
Yes, please go ahead, Gloria. Thank you.
Yeah, welcome. In the issue of local organizations having visibility to the gaps in life-saving service provision and their continuity, and like looking also, like as we said, the issue of SEMARA services, PEP kit services to the survivors and all that. And we all are aware that during this COVID-19 crisis, the most of the focus of services have really totally changed. Everybody or all partners are looking, even the health partners that have been providing these services, their focus has completely changed into the COVID responses. You will even preparedness responses, and at the expense of other services, which is something that partners or organizations should really look into. Now, like for our live experience, like we do not provide some of this, like the PEP kit services directly in 3 of our locations, but we work with health partners on ground through the referral pathways that we have. However, what we do always is to check with them, to check with them on the availability of this. If it is not there, we sometimes come and push through the clusters that we do not have availability of PEP kit in these particular locations. And we are all aware that South Sudan is aware that it is only UNFPA who provides PEP kit in the whole country. And then which helps us to push to UNFPA, and then the PEP kit sometimes get delivered to this partner who is able to support the logistical support to preposition them in those facilities. So for us, we have not, during this crisis, we have the opportunity that there has been availability of these PEP kits in those facilities where we're working in. And then like in one of our locations, we run a one-stop center services where all services are incorporated under one roof. And UNFPA has prepositioned PEP kits in those one-stop centers, which is not only where HealthLink is operating in. We have like around 11 of them in the whole country. So apparently UNFPA has prepositioned PEP kits during this COVID crisis to ensure that even if the health workers who are working in these health facilities have a drift over, have a divert on service provision, basically on COVID preparedness issues, response issues, that other services for like GBV survivors should not be neglected upon. That is how we are trying to manage with the context base. And then for the online case management, this is one thing that the time when we were looking into having this in place, we looked into all the impacts this might create on the survivor, and then also sometimes even on the service provider herself. And we are, to us, we have, a survivor has never left a home telling even the perpetrator that I am going to look for a service in order because you have beaten me or because something ABC has happened to me, but they always look into a convenient time to ensure that the perpetrator is not within them when they are calling for the search of these services. And since we started this approach, we have not encountered that. And then we have always advised that the case workers shouldn't call them to do any follow-up or any other follow-up measures unless to do the follow-up to at the service point where they have been referred to. This, in another way, will minimize any suspicions that might come up in the family about the perpetrator being there and then the survivor being there, so that this survivor cannot totally be blocked from accessing services, whether remotely through the phone call support or face-to-face support. Thank you.
Thank you, Gloria. I think for your response relating to continuity of services, especially clinical management of rape, I think now we're really seeing the value of prepositioning of crucial items, especially now that you have logistical nightmares with regards to ordering, as well as moving those particular essential items. With regards to your the protocols that you have put in place for online GBV caseworkers, I think that also resonates with the ethical guidelines that were issued by the GBV IMS Steering Committee in the last webinar that we had. So we have 2 more questions relating to how do we ensure GBV cases in camps are properly referred to life-saving services. And the last one is relating to if there's a checklist for rapid capacity assessment for women-led grassroots organizations. So over to our resource persons.
Hello, Jessica.
Yes.
Okay.
Yes, please go ahead.
Okay, thank you. I will just say that it's more difficult for women's group to adapt their capacity to respond to the need, because many of them have not resource. And I try to call the small group in the village, in the community, to ask them how they do. They say, oh, we have no fund and we have no resource, and we we are waiting someone to train us to have some equipment to protect ourselves. We need to go to do outreach, but we need some equipment and training. But why I say that it's necessary to support women's group, to give them flexible funds so they can do that. And another one, I say that some victims are blocked by army group in our country, because when they take them slaves and they don't accept to them to go to get health in our center, for example, and they come later, so they cannot get health or get protection for HIV or pregnancy. And another one, I say, it's for us, it's very difficult because we have no electricity in permanence, and we have the network is not every time, and we try to manage all this to give support, but it's not easy for all women group in DRC. But we are happy. We have a chance to get some donors who give us flexible funds, and we have support to UNFPA and other donors, as Sofepadi and Congolese Women's Group.
Thank you so much for your reply. And we really admire the commitment and the dedication to be able to continue and adopt the services amid this very challenging and unprecedented crisis. Does anyone want to respond to the query relating to the checklist on rapid assessment of capacity of local grassroots organizations? Julian, Gloria, Noha, or Kaula?
Well, actually, I don't have an answer. I have a comment, if you allow me.
Yes, of
course. For who asked this question, I am really grateful, because this is a very important point. We need to have one if we don't have it. We need to have one because this is very essential, and it's going to be like a guidance how we are going to go to our next step of our work. So if we have one, we need to share it. If anyone has it. If we don't, I think we need to come up with something. Thank you.
Yes, that is very true. When we started this webinar, it is always in the spirit of collective learning, problem solving, and adaptation. So please, if you have those resources that can be adopted for other country contexts, please share. It can be via the GBV AoR community of practice. And Melissa from UN Women is also sharing that they have created a series of materials regarding violence against women and COVID. She posted the link in the chat, so that may be helpful, especially for our development actors who want to transition to humanitarian response. At this stage, I will turn you over now to Alexina to close our webinar.
Thank you so much, Pam, for the interesting webinar. A big thank you to our resource persons, Julian, Gloria, and Noah, and also to Dr. Howler. We greatly appreciate your time and effort. We'd also like to thank our dear participants for committing your time to participate in today's webinar and also in the past webinars, where we are all trying to explore means and ways of responding to the needs of survivors during COVID-19, which is quite challenging for all of us. But by coming together, I think we are also coming up with some solutions. We would also like to remind you to complete the webinar survey, and the survey link, I think, will be shared very soon by my colleague, Pam. And our next 2 weeks webinar on the 30th, The title is Leave No One Behind, another interesting title and another interesting topic on GBV programming and coordination to address specific needs of women and girls, and also all those people with special needs. So we really thank you, and we urge you to participate in the coming webinar. As my colleague also Jessica mentioned earlier, that it will be maybe our last webinar for now. That is the next webinar. It will be the last webinar, but not last webinar per se, but last monthly webinar, as we are trying to move to monthly webinars. So please come and join us for that webinar because it's quite interesting. We'll be talking about people with special needs, people with disabilities, the LGBTIs, among others. And we would like to hear many good practices on how we can engage meaningfully with all those other groups. So thank you so much. Merci beaucoup, shukran, jazilan. See you next time.